who am I? I'm this guy. I have my office in Lausanne, Switzerland, overlooking the French Alps across Lake Geneva. I've been in private practice since 2004. The story tells that I bought out the office of the orthodontist that treated me a very, very long time ago. I went through my orthodontic residency at the University of Southern California in Los Angeles, and then returned back to Switzerland, where I had this opportunity to buy that office and became a Swiss specialist in orthodontics. I've did my dental training at the University of Geneva in Switzerland, have had a couple of publications on root resorption, on dental materials and so on, and a bit of teaching experience. So when Ryan contacted me a couple of weeks ago, we worked on the agenda that I would be sharing with you over these next 30 minutes. And we first share with you why did I start monitoring my fixed appliance patients. Then I would share with you my implementation journey with DM. And then I wanted to show you how I use the goals for increased efficiency, and in order to show you that, we're going to share a couple of clinical cases, because after all, we're all orthodontists. And last but not least, we'll talk over the overall benefits of using DM for braces. So, traditional orthodontics. We're all orthodontists out here, and the fact is that we love our profession and we always want to do things better. And once in a while, a couple of years into practice, we all ask ourselves that question, is there a way that we can do it smarter? Now, in traditional orthodontics, there are a couple of situations that we've all come across, and we still all come across this situation. The first situation is with this patient. The patient was seen in the office to bond the brackets, and we see all the very extensive malocclusion here. And the question here was, when is the right time to see the patient in? 4 weeks, 6 weeks, 8 weeks, 12 weeks or more? Or is there a true answer? Now the question here, if we had the question here is, when would be the right time to see the patient? Then a second clinical situation here, a pretty easy orthodontic setup here. We've got a crossbite, we've got a pair of buttons and a crisscross elastic. And here as well, when would be the right time to see the patient in? 4 weeks, 6 weeks, 8 weeks, 12 weeks, knowing that the risk is that if there's a too long a time when you get your patient in, you may have a problem of overcorrection. And then you have the other problem coming across. You need to correct that overcorrection. And so that's a second situation. When is the right time to see the patient in? Third clinical situation is bad oral hygiene. Well, the hygiene looks worse on the computer here than on the screen here with the light. It just happens that in Lausanne, Switzerland, luckily not all my patients brush their teeth like that, but I do have some very bad toothbrushes. And so the question here is, how do we do to keep the motivation up for brushing throughout the treatment? And a fourth clinical situation here, you see there's a loose bracket on lower right second premolar, and that can happen throughout the treatment, and that can be always and quickly a big problem, because a loose bracket could induce tooth movements, and we may just lose 2, 3, 4 months in treatment having to realign the tooth. So I get back to this question, how can we do it smarter? And if we come to think of it, how can we do it smarter? It's really a win-win situation for the patients, but also for the orthodontists. First question here is, can we reduce the number of appointments per treatment? Win-win situation for the patients, less visits to the office. Win-win situation for the orthodontist, freeing slots in the schedule. Second question, can we do it smarter? Can we reduce treatment length? And we understand here very quickly the impact of treatment length on the patient and on the orthodontist as a win-win situation. Third question, how can we keep patient motivation high throughout treatments? And that as well would be a win-win situation for the patient, getting the treatment going, being motivated throughout treatment. High motivation means also reduced treatment time. And we also see the impact here for the orthodontist. How can we do it smarter, and how can we better anticipate appointments? How can we better manage emergency appointments? And here we see also the impact that that win-win situation could have on the patient and on the orthodontist. And finally, last but not least, how can we better delegate? Meaning that, is there a way that we can reduce doctor's time to the strict minimum? And sixth question here, can we increase profitability on the orthodontic office? That also is a win-win situation for the patient and for the orthodontist. For the patient, because you're not going to be charging the patient the same as an office visit as you would a virtual visit, if that's the way that you work on that. And obviously, the win-win situation for the orthodontist, increasing profitability. So you see here all these questions that you would ask yourself, how can we really do it smarter? Now, how about my implementation journey with DM and with fixed appliances, with braces? Now, I started using DM with my braces. It was about 6 or 7 years ago. Is that right, Philippe? Yeah. 2015. So, yeah, time flies. Time flies. And basically, my implementation journey, that was 2015, 2016. There was just no scan box. There were no protocols. We just had blue retractors with 4 green dots. Is that right, Philippe? And the patient had to look at himself in the mirror, or a parent had to help the patient. And they weren't even videos, they were pictures. There were about, I think, 8 pictures, is that right? 12 pictures, thank you. 12 pictures that the patient had to take. And so you can imagine how cumbersome that was at the beginning. But I believed in it, and that's when I started. Now also, there was no automated message system. So, well, at the time I was single, and so it wasn't it wasn't a big problem to be sitting in the evening by my computer and sending messages out to my patients. And then as time went on, the scan box came onto the market, the protocols came onto the market, the goals and so on. And as today the product is, it makes it obviously much more easy to implement it in the office. But that's how I started. I was really convinced that it could help me in my office, and that's why I was ready to go over these thresholds, which were kind of challenging at the beginning. Now, I'm a self-ligating user. I use the Speed system. The Speed system is a Canadian bracket system with an active self-ligating clip. I'm not wanting to do here any business for Speed. I don't have any financial interest in Speed. But the reason why I wanted to show this slide to you here is that the Speed system is a nickel titanium clip, and that's whereby the system is an active system, and the initial leveling arch wires are twisted nitinol arch wires, so very, very low forces, very long duration, very biological, and so on. And I realized, and that's only after time and after using the Speed system and monitoring it through DM, that I was really making the most out of DM using this active self-ligating clip through the Speed system, because I really could put the brackets on, put my initial twisted arch wires in, and just let the system work itself out. And the benefits of DM here were pushed to their maximum. The tooth would keep on moving and moving and moving until the system was totally passive. Now that doesn't mean that obviously DM doesn't work with other fixed appliances. Obviously not. But the fact is that with an active self-ligating clip, it would use the impact or the potential of DM to its maximum. Why do I say that? Well, for example, if you use a passive system, well, you'd use obviously a self-ligating clip. You can also push the DM to a very big potential. Maybe a little less if you have a system with elastomerics, a non-self-ligating clip system. But even then, DM is very useful because you are going to have active wires. It's just that the elastics which hold the wires into the brackets are going to deflect, and you will have to change the wires, the elastics a little more often in order to keep the system efficient. Here again, my implementation journey. Well, when did I implement DM for braces? Well, about 2015, 2016. Why did I do that? Because my schedule was becoming difficult to manage, and I just hated the idea of getting patients in the office where just there was no need, real medical need or orthodontic need to see them then, because the wires were still working. So that's when I really went through this thought process and saw the huge impact that DM could have on my office. It was really based initially on appointments and scheduling issues. Early and current challenges, well, I would say obviously the early challenges I came across were the scan process. No scan box, these retractors, and having the patients scanning their teeth, looking at themselves in the mirror. Very cumbersome and very complicated to do. Today, I would say the current challenge is having accurate buccal views. Although the ScanBox Pro is such a huge improvement compared to the initial ScanBox, we still have, with certain patients, I find a bit of difficulty having accurate buccal views, seeing the canine relationship much better, molar relationship really difficult. So that's, I think, a current challenge. And another challenge is having an accurate bite. Because when, for some reason, certain patients, whatever you put in their mouths, when you ask them to bite down, they'll bite in a forward position. So that's, I think, today, as far as the scanning process, are the current challenges. Having accurate buccal views and having an accurate bite. The early challenge was building the protocols. That was a big challenge. Today, there are protocols that are already that you can use and you can adjust to your need. Well, when I started that, there were no protocols, so I had to build my own protocol from scratch. Well, that was over a summer vacation, and I was still single then, so that came across as a good thing. And the weather was bad, so there was no possibility of being on the golf course. So communicating with patients, that also initially was a big challenge because there were no automated messages. Today, with the protocols and automated message system, well, that really makes things much easier for us. And I'd say this is also a current challenge, is keeping patients' motivation high. And I think that's a big issue for all of us, because it just happens that great patients are going to be taking their scans correctly, great patients are going to be brushing well, great patients are going to be wearing their rubber bands well. Bad patients or bad cooperators already start by not scanning their teeth. So that is something which I think we can all think of in order to make that challenge a little less challenging. What would be tips of best practices if I were to share with you, for those of you maybe that are less familiar of using DM with braces? I would say implementing DM, well, I don't want to scare you here. Implementing DM is an everlasting process. Well, I'd say maybe it's more of a step-by-step process. let's not be too ambitious. Let's not want to have the perfect system right from day one, because it'll change. And you may start using DM for hygiene monitoring, or then to braces, and then you move on with some more implementation of DM. Don't want to be too overly ambitious, because it is something which is going to be changing on and on and on. You may add some things, you may retrieve some other things. Another tip that I would give is implementing DM for braces, for example, is a great opportunity to think over all your procedures, as far as the clinical procedures, as far as emergency procedures. What I'm saying by that is that, for example, and I remember that was an exercise I made that we had done, Philippe, in Paris a couple of years ago when the protocols came up. And you came up and say, why don't you ask yourself that question? What happens if there is a disengaged arch wire? How do you deal with that? And okay, so I asked myself the question, disengaged arch wire. Do I want to get the patient in? Yes, no. Do I want the staff involved? Yes, no. Do I want to inform the patient? Yes, no. And building on that, going through all the clinical procedures, then that's how you build the protocols. And today we can also use the current protocols and adjust them to the ones that fit best the way you'd like to implement it in the office. And last but not least is designating one staff person, your DMC. All the staff in the office, I think, well, obviously need to be aware of what's going on and what is DM all about. But I think it's important that you have one designated person, your DMC. Now, last year, DM came up with a photo monitoring for braces and using the goals. And that surely is a paradigm shift in patient follow-up. And what do I mean with that? Well, before that, you'd see the patient on a routine protocol, 6 weeks out, 8 weeks out, or so on. But that really doesn't really mean the reality of what were the patient need, what were the patient's needs. And using the goals, meaning that you like to get the patient in when you have specific steps in treatment that have been achieved. Now, if we have a look at the patient's journey with braces, I would say, okay, let's go over an 18 to 24 month treatment, 5 arch wire changes, 11 to 15 appointments, just to give an idea, just for numbers like this. Now, how do I deal with that? Clinically, I would have an initial phase of treatment. That phase is when you'd be changing the arch wires, doing rotation correction, leveling, aligning, leveling curve of SPI, and so on. At that point, what will I monitor specifically? Well, I'll have some goals. And the interesting thing I find with goals, or my experience with them, is that as the treatment goes on, I adjust the goals. And it's me as a doctor that I'm going to change the goals throughout the treatment. Very easy to do. The patient is sitting on the dental chair, the computer's behind, I'm just going to change the goal depending on the stage in the treatment. And for initial bonding of the patient, well, that goal will be arch wire facility. So I'm going to set up that goal. And the second goal that I'm going to set up, but in due course when I will have already stepped up to stiffer arch wire, is overbite correction with reverse curve of SPI or correcting debite and so on. So initially, at the beginning of the treatment, the goals that I'm going to set up is arch wire passivity and overbite. And at that time, obviously, there is going to be observation of clinical situations, arch wire disengagements, bracket debonding, and so on. The intermediate phase of treatment is when you have larger tooth movements and mass tooth movements, space closure, class 1 correction, midline correction. This is when you use intermaxillary elastics. At that second phase of treatment, intermediate phase, I'm going to change the goals. At that point, my goals are going to be, for example, class 1 correction. At that point, my goals are going to be midline correction. or space closure. And I'm going to have patient compliance that I'm going to monitor very closely through hygiene and elastics. And finally, I'm going to have the finishing phase, which are going to be the little steps in the wires to get the occlusion settling, to get the case looking good, and so on. So they're very much smaller finishing movements. At that point, I don't feel or use the goals anymore because the broader tooth movements are over. The overall treatment is finished and you're just looking at some detailing here. So goals don't really have any meaning at that point, but observations are really, really important because at that point, if you have an open self-ligating clip and the tooth starts moving, then you may be in trouble and you lose 2-3 months of treatment having to recapture the tooth. Debonding brackets, obviously. All that has a very big impact at that point in treatment. So what I mean by that is that during the finishing stages in treatments, I won't be using the goals anymore. I will deactivate all the goals that I will have set up for that patient, but obviously the observation goes on as far as all the clinical situations. This is here on this screen the dashboard which shows the goals that have been achieved. You will have that on the dashboard. Arch wire passivity has been achieved on such and such a date. Arch wire on the upper, on the lower. You can choose which one that you would like. And if goals have not been achieved, well, you get that information on the dashboard, and you'll find that information on that patient's chart here. So if we have a look at a couple of clinical cases together, the first case I wanted to share with you is a case with a Carrière motion appliance. I'm a big user of that appliance because I really like the idea of getting into class 1 before moving on to the second stage in treatment. So the patient and also the patient's collaboration is great at the beginning of the treatment, and that's when the elastics are going to be worn to correct a class 2 into a class 1. So in this, in Anila's case here, she's got upper crowding, which is combined with a class 2 dental, right and left, and pretty aligned lower teeth. And so the treatment plan here was going to have a Carrière motion appliance to start with, and then move on to fixed appliance or an aligner treatment for the second phase. So I'm going to set up goals here, which are going to be class 1, canine, right and left. So far, I've never used the molar relationship because I find that with the buccal views, it's not accurate enough. So I am going to use the canine relationship, but I think it gives a very, very good idea clinically of what's going on with the case, because if all the teeth are in, they don't have asymmetric extractions or so on. If the canines are in class 1, the molars are pretty much going to be in class 1 as well. So I'm going to set up the goal here. Class 1 canine right, class 1 canine left. And here's the case as we start in September 2021. We had the cuspid on the right side was 5 mm class 2, 6 mm class 2 on the left side. And this is Anila's case as we went on from October to 30th of November. Cuspids got corrected from 5 to 2 mm on the right side, 6 to 3 mm on the left side. So I didn't get to see the patient in then. There was no need. I could just follow up the patient with the dashboard here. And I could see here she was a great cooperator. At that point, I would ask my DMC to just reschedule the appointments. I don't need to get the patient in at that point, and just to send some extra rubber bands. And then we move on to January of 2022, and patient was in class 1. If we have a treatment summary here, the patient's the treatment time was 7 months to get the canines into class 1 for that first phase treatment with the motion appliance. Number of in-office appointments, there were 6 in-office appointments, but out of these 6 in-office appointments, 5 were emergency appointments. What kind of emergencies were there? There was one where her lower S6 retainer was hurting, so she needed to come in and we need to kind of make a little cut in the appliance. She lost her appliance on the lower twice, and she needed to come in for impressions and so on. And that's why you do get here 5 emergency appointments, because I just wanted to count all of them here. There was no reason for me to hide any kind of information from you, so that was the reality. So yes, she was a great cooperator with her elastics, but okay, a bit of problems with her lower retainer. But what that means is that they were basically excluding the emergency appointments. There were 4 appointments which were saved, and if we count that per appointment is like a 5-minute doctor's time, then we are here at 20 minutes saved of doctor's time over a 7-month treatment. Now, how about Alyssa? Alyssa was, she had a problem with a crossbite that you can see here on the right side between the second premolar and first molar teeth. And you see how the upper arch is kind of distorted. And the treatment here was going to be, and the goal here, so the goal here that I was going to set up was correction of the crossbite. There was no reason for me to get the patients in before the crossbite was going to be corrected. So I set up that goal, crossbite, correction of crossbite right. Patient started treatment. And so just to show you the way I designed the quad helix here, which is the appliance I used in this specific case to correct that crossbite, is that I just shortened the arm on the right side because of the fact that it was only the second premolar and first molar which were in crossbite. So if we have a look at the case here, that was the case in May of last year, where you can see really well the crossbite. And July of that same year, the crossbite was corrected. You see here very nicely with these scans how the correction was made. Now, I did not want to, so that's when I got the information crossbite corrected, because the goal was achieved, and I purposely didn't want to stop the treatment there, but I wanted to get a bit of overcorrection here, and so that's why we extended the time with a quad helix in order to have that overcorrection of that crossbite on the right side. Treatment time with the quad helix was 9 months. Number of in-office appointments, only 2. 0 emergencies. And so how many check appointments were saved? I put here 4. Why did I put 4 here? Because I would see patients normally, if it weren't with DM, every 6 weeks. And so that's why from every 6 weeks on a 9-month period, I saved 4 appointments. And if we count 5 minutes of doctor's time per appointment, it's a 20 minutes saving of doctor's time throughout 9 months of treatment. Now, how about this case here of fixed appliances? This case was, as you may see on the pictures, a case of missing upper lateral incisors, right and left, low crowding. And so the treatment plan involved extractions of the lower second premolars and fixed appliances upper and lower. The patient here has got that blocked out lower right canine, midlines are off. And so here, what did I do with the goals? In this case, like on most of the cases, goals evolve as the treatment evolves. So the first goal which I was going to set up here was arch wire passivity, upper and lower. And once the arch wires were going to be passive, I would have stepped up to thicker arch wires and stainless steel arch wires with reverse curve of SPI. And at that point, I would set up a different goal, which would be overbite correction. Patient was in deep bite. At that point specifically, there's no reason to set up that goal before. I would put normal overbite. And then we have space closure and so on, and I would set up a different goal, which would be midline correction. So this is my example for this case. But obviously what I wanted to show here is that goals evolve as treatment evolves. So here's the case of that patient in August of last year with a tremendous amount of low crowding. The teeth were extracted on the back, the lower second premolars. look at the case on 20th of December. The wires were changed because I did get the notification of passive arch wire, but the patient only came into the office, I think it was in November. So from August to November, patient wasn't seen in the office, and she was just tracking, doing her scans until I get the notification of the passive arch wires. Treatment time. So the treatment time here is not until the finished case, because the case is still in treatment, but over the 7 months that I showed and shared with you, the patient had 6 in-office appointments, but 5 emergencies. So here it seems a lot, but if you exclude the emergencies, there's only 1 office appointment. So the emergencies here was, there was she debonded her bitramps twice. There was twice there were loose brackets, and once there was an arch wire disengagement, and that's why the patient had to be seen into the office for these specific emergencies. How many appointments were saved in the office? 4, and if you count 5 minutes per doctor's time per appointment, that's a saving of 20 minutes of doctor's time. And here in this case, we have another case that I wanted to share with you with fixed appliances. Here again, we've got upper moderate crowding, lower moderate to severe crowding with deep bite, class 1 right and left. That patient with retroclined incisors was going to be treated non-extraction with upper and lower fixed appliances and bitramps behind her upper central incisors. Here as well, goals evolve as treatment evolves. So goal number 1 was going to be setting up passive arch wires. Once the arch wires were going to be passive, then we will move on to stiffer arch wires and so on, and then we would have a second goal into treatment, which will be normal overbite. So that's how the goal setting was going to be set up, or was going to be set up throughout treatment. That is the view on the left side in February of last year, with that tremendous amount of lower crowding. And as time goes on, that was in September, also already nice alignment. Patient wasn't seen in the office. February to September is 7 months. It's kind of interesting to see how you modulate the appointments based on passive arch wires. And here the arch wires was still active, so patient wasn't seen in the office. Over these 12 months of treatment, again, the treatment is not finished yet, the patient was seen in the office 4 times, but out of these 4, 3 were emergency appointments. If I recall, I think there was 1 loose bracket, and twice the arch wire was disengaged. And you see here how important it is to have these observations which are monitored and detected by AI, because if you don't monitor your patient, then you may have some big problems here. How many appointments were seen? Again, this is based on a 6-week appointment checkup. 7 appointments were saved, and here again, if you count 5 minutes of doctor's time per appointment, it's saving 35 minutes of doctor's time over a 12-month period. Okay, so having shared with you all these cases, what about the overall benefits of using DM for fixed appliances? First, I would say recalls a basis, the clinical evaluation. With DM, basically, the evaluation is done at every scan. So I ask my patients with fixed appliances to scan every 2 weeks, which for me seems reasonable and not too cumbersome for the patients. But that means that there's an evaluation every 2 weeks. With no DM, well, you're going to evaluate at the dental chair itself. Appointment frequencies with DM is when needed. Don't get the patients in when they don't need to come in. And with no DM, well, it's on a base protocol, but maybe most of the time the patients don't really need to come in at that specific time, which means less in-office appointments with DM, more in-office appointments without DM. Patient motivation with DM is going to be continuous because the patients are going to receive messages through the protocol that you will have set up, whereas without DM, you'll try and do your best to motivate the patient at the dental chair, but there's no way you can motivate patient between appointments, and that can be 4 weeks, 6 weeks, or 8 weeks. That's a long time for patients to get demotivated. Same thing for oral hygiene. And then also there's adjusting the appointment time to repair for breakage. For example, if with DM you know that there's a loose bracket, well, you're going to adjust the appointments to rebond that bracket. Without DM, you're going to have that bad surprise that happens at the worst time of the day, obviously, and either you're going to stress out the whole team of your office because you're going to say, oh, we need to get the bracket on right now, or you're going to reschedule the appointments and the patients need to come back. Reduced treatment time, it's more of a tendency. I don't like really to talk about treatment time as far as reduced treatment time or more treatment time, because treatment time is really based on so many different factors, including patient motivation, elastic wear, and how much detail you want to put into your finishing. So that's why I won't really spend too much time on that. And increased efficiency on office profitability, I would say certainly with DM, because you don't get the patients in the office when you don't need to. So remember those questions that we ask ourselves. How can we do it smarter? Go through all the different questions here. I won't go over these with you again, but basically that may be a basis of this discussion, of this workshop, which we'll do, which will be hosted by Thierry and Rana in a couple of minutes. And if I were to share with you what DM is all about with patients, I think it's all about patient care. And C is for the communicate, and obviously you communicate with the patients through the message systems, whether they're automated, whether they're personalized. A is anticipate, anticipating patients' need, anticipating future appointments. R is respect, and respecting here is respecting patients' time. And I think we shouldn't overestimate what this respect is all about, because today we get so busy and patients have got all these, especially these teenagers, so many activities doing here, going there, and so respecting that time I think is really something we should never underestimate. And E is encourage through motivation, through messages and so on. So for me, as I said, DM is all about patient care, and on this I'd like to thank you for your kind attention.